My name is Abhishek Solanki. I am an assistant professor of radiation oncology at Loyola University of Chicago and Edward Hines VA Hospital. Today, we compare two patient cases that relate to the use of radiotherapy for brain metastases. These two cases have similarities, yet the recommended treatments may be different. Let's look at the cases. Patient Case 1. Our first case is Michael. Michael is a 59-year-old gentleman with a history of stage 3B non-small cell lung cancer of the right upper lobe, treated with chemoradiotherapy, followed by durvalumab, with completion of adjuvant treatment 6 months ago. He presented to the ER with a new focal seizure, and MRI revealed 3 brain metastases, 2 in the right frontal lobe measuring 1 cm, and 1 in the left temporal lobe measuring 2.6 centimeters with mild vasogenic edema. Extracranial imaging revealed minimal extracranial disease, and he was seen by a neurosurgery colleague who recommended against surgical intervention. Michael will undergo palliative radiotherapy to the brain. Patient case number 2. Our second case is Jim. Jim is a 58-year-old gentleman with a history of stage 3B non-small cell lung cancer of the right upper lobe, treated with chemoradiotherapy, followed by durvalumab approximately 8 months ago. He presented with a focal seizure as well. MRI revealed 17 brain metastases distributed throughout the brain, with a dominant lesion in the left temporal lobe measuring 3 centimeters, surrounded by mild vasogenic edema. Jim's extracranial imaging also revealed minimal disease, and he was seen by a neurosurgeon as well who recommended against surgery. Jim will also undergo palliative radiotherapy to the brain. As you can see, both cases are very similar, but there are some differences. Would the differences lead your choice of treatment in a different direction, or would both patients receive the same treatment? If treatment is different, what is the difference that changes your choice of treatment? Historically, patients with brain metastases were treated with whole brain radiotherapy for decades. The rationale was that due to limited detailed imaging of small brain metastases, less sophisticated radiation planning and image guidance, and poor CNS penetration of systemic therapies, the whole brain needed to be treated with radiation to treat both the visible and occult brain metastases to prevent morbidity and potentially mortality. However, as brain imaging and radiation treatment planning have improved, stereotactic radiosurgery, or SRS, has become increasingly delivered for limited brain metastases, with the definition of limited brain metastases being approximately 1 to 3 or 4 brain metastases. The outcome of SRS alone, whole brain radiotherapy, and whole brain radiotherapy with SRS as a boost have been tested through multiple clinical trials. Ultimately, in patients with limited brain metastases, whole brain radiotherapy improves intracranial control over SRS, but at the cost of neurocognitive toxicity to patients, without any improvement in survival. So, for most patients with limited brain metastases, patients are typically treated with SRS. For those with a greater number of brain metastases, SRS versus whole brain radiotherapy is controversial. The JLGK0901 prospective observational study from Japan of patients treated with SRS to up to 10 brain metastases revealed that patients with 5 to 10 brain metastases had similar survival compared to those with fewer metastases, as well as acceptable toxicity, suggesting that SRS may be a promising approach for these patients. However, comparative data for patients with greater than 4 brain metastases of SRS versus whole brain is not available at the time to guide treatment. The CCTG-CE7 trial is comparing SRS with whole brain radiotherapy for patients with 5 to 15 metastases and is currently accruing and will hopefully give us information about the incremental benefit and toxicity of each treatment approach. Until the results of the study are available, whole brain radiotherapy remains a standard of care for patients who have multiple brain metastases, particularly those with greater than 10 brain metastases. How cases are related. Both cases describe patients who have newly diagnosed brain metastases from previously locally advanced non-metastatic non-small cell lung cancer. Both patients have neurologic symptoms from the brain metastases, and imaging suggested that both patients have limited extracranial disease. The patient in the first case has limited brain metastases with 3 lesions, while the patient in the second case has many brain metastases with 17 lesions. Multiple randomized trials support SRS alone for patients with limited brain metastases, while a prospective observational study suggests SRS may be acceptable even in patients with 10 brain metastases. However, there are very limited data for SRS alone for patients with more than 10 brain metastases, and thus most patients with such a high volume of brain metastases get treated with whole brain radiotherapy. Answer: there is only one difference between the characteristics of these two cases: the number of brain metastases. The difference in the number of brain metastases is the key deciding factor for treatment. For case 1, you will recall Michael has 3 brain metastases, and so the best option for him would be treatment with SRS alone. In case 2, you recall that Jim has 17 brain metastases, and so the best treatment option for him would be whole brain radiotherapy. Thank you for listening to this week's episode of the ASCO eLearning Weekly podcast. For more information on the radiotherapeutic management of brain metastases, including additional patient cases and opportunities for self-evaluation, visit the Comprehensive eLearning Center at elearning.asco.org.
The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.